This video demonstrates the intake, assessment, treatment planning, treatment, and home care for hyperkyphosis. Hyperkyphosis is a postural disorder that is characterized by an excess curvature in the T-spine. It can become present due to osteoporosis, ankylosing spondylitis, Pott's disease, Scheuermann's disease, sustained poor posture. It may be a result of occupational or recreational habits, and in many cases, it can be caused by overstrengthened pecs. In hyperkyphosis, some muscles will be weak and some muscles will be overactive. The muscles that will be weak are the deep neck flexors, as well as the scapular stabilizers, retractors, and depressors, and the overactive muscles will include the upper trapezius, levator scapula, and the pectoral group. The following is based on the specific scenario that was presented to us. Stacy is a 22-year-old student who has been experiencing pain and decreased range of motion in her posterior neck and upper back. Upon assessment, you notice that she has moderate hyperkyphosis caused by improper posture and biomechanics.
Okay, hi Susie. I see that you've filled out all of your information here. So I have your phone number, your address. I see that you're a student at Georgian College, and you have been in for a massage before, and you weren't referred by your doctor for today's treatment. I can see that you do have a family doctor though. So I'd just like to ask you some questions about your history, your health history before we get started to make sure that we can have a safe and effective treatment. So I'm just going to go through a number of things and you can just let me know if any of those pertain to you. So I'm going to start with your cardiovascular. Have you ever had, or anyone in your family ever had, high or low blood pressure, a chronic congestive heart failure, a heart attack, a phlebitis, a stroke? Have anyone ever had a pacemaker or heart disease? No. And for respiratory, has anyone ever in your family, or have you ever had a chronic cough, shortness of breath, bronchitis, asthma, or emphysema? And has same question for infection, so hepatitis, skin conditions, TB, HIV, or herpes. Have you ever had a loss of sensation anywhere? And do you have diabetes? No. Any allergies or any hypersensitivities to anything? No. And do you have epilepsy, cancer? And do you have any other types of skin conditions or arthritis? And is there a family history of arthritis of any kind? No. So I can see that you're in today for neck pain. So do you have a history of headaches or a history of migraines?
No.
No? No. Do you have any vision problems, vision loss, ear problems, or hearing loss? No, none of those pertain. And are you on any current medications? And are you receiving treatment from another healthcare professional? No. No. And I can see that there's been no surgeries. Do you have any other medical conditions such as digestive conditions, osteoporosis, or any mental health that you would like to let us know about? No. And do you have any internal pins, wires, artificial joints, surgical elastics, anything like that? No. And okay, great. Okay, so now I'd like to ask you some more questions about the pain that you're having in your neck so we can start to come down to what's actually happening in there. So can you tell me when you started noticing the pain?
I noticed it towards the beginning of the school year, but as midterms came up and I started studying, I noticed that it progressively got worse.
Okay. And how long does it usually last for?
Until the end of the day usually.
Okay, and how often does it happen?
Daily.
Every day?
Yeah.
Can you describe the pain?
It's kind of stiff.
Okay.
A little stiff.
And what causes the pain?
Usually when I'm studying, sometimes when I'm driving to and from the college.
Okay. And can you rate the pain on a scale of 1 to 10, 10 being the worst?
Well, it kind of starts at a 3 or a 4, and then it goes to about a 7 by the end of the day, I'd say.
Okay. And every day you would say it ends at a 7?
Yeah.
Okay. And what aggravates it?
Studying.
Just studying?
So maybe sitting at a desk or a computer for doing homework.
And is there anything that gives you relief?
Sometimes I'll take Advil. Hot bath usually helps, and just resting.
Okay. And do you take any other medication besides the Advil for it?
No, just Advil.
And is there anything else you'd like to tell me about it?
Well, I did notice that I started to get some headaches.
Okay.
Just sometimes by the end of the day when the pain's like really bad.
Okay, and can you describe where you would get the headaches typically?
Around here, I guess.
Okay.
Yeah.
Okay, I'd just like to know what your typical sleeping position would be.
Usually I sleep on my side, kind of in like a fetal position.
A fetal position?
Yeah.
And have you ever had any, or had you have any recent injury to anywhere?
No, nothing.
And what position do you find yourself most in during a typical day?
Oh, definitely like sitting at a desk, doing homework, reading, because I'm a student, right? So.
Okay, perfect. So I'd like you to, if you could just take a couple minutes and fill out this neck disability index. Mm-hmm. There's 10 different sections, and there's going to be 6 options in each of them. And I'd like you if you could just pick one of the options in each section that most represents how you feel of the pain. So I'll just give you that if you could take a couple minutes to fill that out.
Okay.
The answers this patient would likely give for the neck disability index are, for section 1, pain intensity, moderate neck pain. Section 2, personal care. I can look after myself normally, but it causes extra pain. Section 3, lifting. I can lift heavy objects, but it gives me pain. Section 4, reading. I can do most of my usual work, but not more. Section 5, headaches, moderate headache and frequently. Section 6, concentration, a fair degree of difficulty concentrating. Section 7, work, moderately for 2 to 3 hours per night. Section 8, driving, moderate neck pain during driving. Section 9, sleeping. My sleep is mildly disturbed for up to 1 to 2 hours. Section 10, recreation. I am able to engage in all my recreational activities with some neck pain.
Okay, so an important part of the assessment process is to do a postural analysis of the patient. What we're going to do is we are going to start by analyzing at the feet, and we are going to move up to the head. A lot of patients with hyperkyphosis will present with similar symptoms. What you will notice is an anterior head carriage, which means that their head will be resting forwards like so, and they may also have rounded shoulders. So paying attention to that can also help to diagnose a hyperkyphosis patient. And if we turn this way as well, you will also notice the kyphosis in the T-spine, and you will also notice possibly a lordosis, a sway back in the L-spine. You may also see a flat back as well. That's a common representation. Alright, so the next important thing to do is ranges of motion. What we're also going to do is some rule-outs as well, just to make sure that it is not specifically the C-spine that is affected. We want to make sure that it's not TMJ, the shoulder, the elbow, the wrist, or the fingers. So what we're going to be doing is we are going to be starting with the TMJ. We're leaving C-spine to the last just due to the fact that it is the most painful ranges of motion. So what I'm going to do is we are going to do an active range of motion, and then we are going to add some overpressure in 2 different planes. For assessing the TMJ, we're going to be doing it in 2 different planes. So what I'm going to be testing is protrusion first. So what you're going to do is you're going to push your chin outwards, like so. And I'm just going to add some overpressure. Do you feel any pain?
No.
Okay. And then I'm going to get you to retract your jaw backwards, so like you're pulling your chin in. Okay. And then add some overpressure. No pain? Okay. and then I'm going to get you to shift your jaw side to side, okay? So starting with this side, I'm going to add some overpressure. Feel any pain? And then the opposite way. Any pain? Okay. Alright, so it's a negative for the TMJ. Okay, and now we're going to move on to a peripheral joint scan from the C-spine, starting with the shoulder. I'm just going to get you to stand up just a little bit here. And what I'm going to get you to do is I'm going to get you to flex at the shoulder, and I'm just going to add some overpressure, okay? So there, and we'll add some overpressure. Do you feel any pain? And then if you were to extend, and again, just adding some overpressure. Any pain? Okay. And then I'm going to get you to reach your arm out this way, and then you are going to be bringing it backwards. So we're horizontally abducting the arm, and you're just going to add some, I'm going to add some pressure. And then you're going to go across your body this way. Do you feel any pain with either of those? Okay. So that's a negative for the shoulder. But if there had been, there would have been pain in a hyperkyphosis patient, most likely upon flexion, extension, horizontal adduction, as well as adduction. All right, and the next step is we are going to be assessing the elbow. So you can actually have a seat, make yourself comfortable. So what you're going to be doing is, again, you're going to be flexing your elbow, and I'm just going to add some overpressure. Do you feel any pain there? And then extension. And I'm going to add overpressure. No pain? Okay, and then the next thing you're going to do is having your hand, your palm straight up. You're going to turn your hand over this way so it faces the ground. And do you feel any pain when I add overpressure? You're okay? And then if you were to go the opposite direction, and I'm just going to add some overpressure. No pain with that either? Okay, so that's also a negative for the elbow. Okay, and the next thing we're going to assess is the wrist and the fingers. So I'm going to get you to flex your wrist upwards like so, and I'm going to add some overpressure. Do you feel any pain? Okay, and then if you were to extend your wrist, and I'll add overpressure again. Any pain with that? Okay, and then you're also going to take your hand to a neutral position. You're going to turn it inwards towards your body. Do you feel any pain? If I add some overpressure, you're okay? And then if you were to go the opposite direction, and I'll add some overpressure. No pain? Okay. And then the last thing we are going to do is we are going to assess the fingers to complete our peripheral joint scan. So I'm going to get you to flex your fingers. No pain? No pain with overpressure? Okay, and then you're going to extend. Any pain there? Okay. And then you're going to separate and close your fingers. Do you feel any pain with that as well? And then you're going to go through each individual one, and you're going to add the overpressure. And then as we're closing, we're adding overpressure as well. Okay, and after completing my peripheral joint scan on one side, I would have moved on to the other side and made sure that I tested bilaterally on both sides. The last range of motion is generally the most painful for hyperkyphosis patients, so that is why I've left it to the last. It is at the C-spine, so we're going to do a couple ranges of motion with this, in active, passive, and resisted range of motion. So first we are going to do active, so you're going to extend your head backwards. Do you feel any pain with that? No? No. Okay, and then I'm going to get you to flex forward. Do you feel any pain? No pain. And then if you were to go to the, your ear to the shoulder. Okay, and then the opposite side, do you feel any pain with either of those ranges? Okay, and then if you were to rotate your head, and then rotate the opposite way. Okay. During active range of motion, the hyperkyphosis patient may actually feel a bit of pain during left and right rotation and flexion, and lateral flexion as well too. So the next thing we are going to do is passive range of motion. I have my client supine on the table, and her head is in my hands. And I'm just going to be taking her through the motions that we did previously in active range of motion, but her full weight is in my hands. So you can just completely relax there. Tabitha, are you comfortable? Mm-hmm. Okay, and I'm going to take her into passive extension. Does that feel okay? Mm-hmm. Okay. And then flexion. You're okay there? Mm-hmm. And then we're going to go into lateral flexion. You're okay? Mm-hmm. Lateral flexion the other way. And lastly, we're going to do rotation. You're okay there, Tabitha?
Mm-hmm.
And the other way. Okay, and depending on the direction that we are moving the head, the client may complain of a slight stretch due to the hypertonicity in some of the muscles in the upper back and the neck. Okay, and lastly we are going to do resisted range of motion, which tests for contractile structures involved with hyperkyphosis. So what I'm going to get you to do, Tabitha, is we're going to do the same motions like you did before. And you're going to be extending backwards, and what I'm going to do is I'm going to get you to build the contraction for 5 seconds, and then we're going to hold the contraction for 5 seconds, and I'm going to resist against you, okay?
Okay.
Alright, so extending backwards for 1, 2, 3, 4, 5, and hold for 5, 4, 3, 2, 1. So that's grade 5 out of 5, which means she had full strength. And then next we are going to be doing flexion in resisted range. So it's the same thing, building for 5 and holding for 5. So 1, 2, 3, 4, 5, hold 5, 4, 3, 2, 1. No pain? Okay. And then I'm going to get you to bring your ear towards your shoulder, and we're going to do the same thing. So 1, 2, 3, 4, 5, hold 5, 4, 3, 2, 1. Okay, and then lastly this side. So 1, 2, 3, 4, 5, hold 5, 4, 3, 2, 1. Okay, and the last range we are going to do is right and left rotation. So you're going to be turning your head this way, and I'm going to be holding, resisting, okay? So I'll build for 5. 1, 2, 3, 4, 5, and then hold 5, 4, 3, 2, 1. Any pain with that?
No.
And then this way, we're going to hold for 5 and build for 5. So 1, 2, 3, 4, 5, hold 5, 4, 3, 2, 1. No pain?
No.
Okay, so we're going to do a series of special tests just to make sure that we're ruling out that it isn't anything else, such as a space-occupying lesion. It could be the deep neck flexors that are affected, in this case for a hyperkyphosis patient, and we're also going to assess the pec length. First, we are going to start with the deep neck flexors. So I'm having my patient lay on the table supine. What I'm going to get you to do, Tabitha, is I'm going to get you to bring your knees up onto the table here. Yeah, just like so. So they're tucked in here. Alright, and what I'm going to get you to do is I'm going to get you to flex your head like we were doing earlier in range of motion. So you're going to bring your chin towards your chest, and we're going to hold for 10 seconds in just a second, okay? So I'll tell you when. This is just testing the vertebral muscles, okay? Alright, so you're going to go. And we're holding for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay? Alright, so and we would also test for endurance, so we would do this possibly 10 times. If the client cannot go through with the test after the first initial one, that is positive, and even after doing the endurance trials of the neck flexion as well, it can be presented as positive. Okay, so this particular test we're going to do is a special test for muscle length. A lot of hyperkyphosis patients have hypertonicity in their pecs, so this is just a way that we can confirm how tight the pecs are. So what I'm going to do is we're going to get our patient to lay at the edge of the table, supine. So I'm going to start by bringing my client's arm into 30 degrees of abduction. And we're going to be noting how far the arm goes down towards the side of the table. And this should give us a pretty good indication of how tight the pecs are. We're going to move to 90 degrees of abduction. You're okay there? And then lastly 120. Okay, and another important test that we're going to do today is the slumps test. This test for a space-occupying lesion in the spine. So what I'm going to do, Tabitha, is we already have her seated, and what you're going to do is you're going to slump as though you're sitting at a desk, and you're going to flex your neck towards your chin, and I'm going to add some overpressure. And at the same time, I'm going to reach down. Do you feel any pain there, Tabitha?
No.
Always check before moving into the extension of the leg. And then we're going to add extension. Do you feel any pain, Tabitha? Okay, so that's a negative. If it had been positive, it would have reproduced the symptoms of pain and it would have been in the spine. A person who is experiencing hyperkyphosis would find limitations in daily activities such as sitting, standing, or driving for extended periods. Even taking deep breaths would be painful, and any throwing activities.
So Susie, I have your treatment plan here. We're going to work on maintaining your range of motion in your C-spine, so in your neck. So we're going to maintain the flexion and the rotation and the lateral side-to-side flexion. We're going to work on reducing the trigger points in your pec major. We're going to do that with some specific compression, some effleurage, and we're going to try to reduce it from the 6 out of 10 that it is down to hopefully a 3 or less. And after we do the trigger point release, we're also going to make sure that we stretch it so that it doesn't come back again. And we're also going to work on reducing the hypertonicity in your upper traps and your SCM by doing some specific compression, some passive stretching, and some effleurage and petrissage. And because during the assessment, we didn't find any space-occupying lesions or disc herniations, and you don't have any problems with asthma or bronchitis, then we can go ahead with this treatment. Those would be reasons why we wouldn't be able to go ahead. And hopefully by the end of this treatment, by August 5th, we'll have everything sorted out.
For today's treatment, I'd like to begin with you on your stomach. So I would like you to lay between the top and bottom sheets. I will be working on your upper back and neck areas, so skin-on-skin contact is best. So if you're comfortable, I'd ask you to remove your shirt and your bra. Again, get between the sheets. I'm going to leave the room and wash my hands, and I will knock before we enter in. Do I have your consent to treat?
Yes.
So I'm going to begin by undraping my client's back. Start by using some cool wash hydrotherapy to stimulate the muscles. Does that feel okay?
Yes.
Good. Now I'm going to dry off the area because I want to do a fascial assessment, because again I am working on fascial adhesions. So I did the fascial assessment. Now I'm just going to use an effleurage technique without any lotion to warm up the tissue beforehand. Is that okay?
Yes.
And then I'm going to use my myofascial connective tissue technique to start loosening those fascial adhesions in the rhomboid and trapezius muscles, mainly the lower and middle trapezius. I'm just going to come over to the other side and do the same thing. So now I'm ready to begin effleurage and add some lotion. drape the client's back, and then I will ask her to turn over onto her back. So Cheryl, I'd like you to shimmy down the table so that the top of your head is parallel with the top of the table. Good, okay. So while you're there, I'm just going to ask you to do a small push-up, and I'm going to move this pillow that's underneath your belly. And on the count of 3, I'm just going to grab a hold of the sheets, and then I want you to turn towards me onto your back. Do you understand?
Yes.
Okay, 1, 2, 3. Now that I have my client in this position, I am going to do a V-drape to access pec major, both the attachments and any trigger points that may be potentially in those muscles. So I'll begin by tucking one shoulder. So I'm going to begin this part of the treatment after the drape by doing a fascial assessment of pec major, because again I want to do some connective tissue techniques before I do some indirect techniques, and then some petrissage to address any potential trigger points. So again, noting which way the fascia adheres, and then I'm just going to do again, some smaller myofascial technique. On both sides. So after I complete the O&I technique, I add some lotion to my hands, some general effleurage in the area, and then I'm going to begin by doing some specific kneading. And I can tell that I'm on a trigger point because I notice a twitch response as well as an autonomic response from my client. And I'm going to ask my client if in this area she feels the pain level higher than a 4.
About a 6.
About a 6. So I will just compress and hold for a few seconds until I feel the top muscle band relax a little bit underneath my fingertips. And then I will flush the area with some effleurage. And then I will begin on the other side. If I locate any trigger points, I will note the twitch response. I will notice and ask my client if she feels any referral pain. And then I will compress for a few seconds, flushing the area with some effleurage. At this point, I will redrape her so that I can do the stretch of the pec major muscle. I'll just slowly take my time. I'll ask my client to remove her arm from underneath the sheet, point your elbow to the sky. You can relax your arm. And I will do the same on the other side. Again, asking my client to pull her arm out from underneath the sheet. And I will tap her. Relax the arm on the table. I'm just going to take the client's arm in my hand, and I'm going to stretch it in 3 different degrees. Let me know if you feel any pain or discomfort. So at this part of the treatment, I'm going to focus on my client's hypertonicity within both the upper trapezius and SCM. So I'll begin by just doing some broad compression on the shoulders to start to stretch those tight muscles. And then I'll just spread the lotion around using an effleurage technique. Start to warm up the area. I will use muscle squeezing to assess the resting muscle tension. You're okay with that pressure? Interchange effleurage and some specific kneading. I will also at this time begin to post and access the suboccipital muscles. Pressure. just doing some specific kneading along the attachment points for the suboccipitals. Relieve the tension there. I can use some O&I technique at this point to relax those muscles. And just do a gentle stretch. You okay? So again, I'm just going to check the resting muscle tension. And finish with some head flush. So now I'm going to conclude my treatment by using a little bit of effleurage. Cheryl, this concludes our treatment for today. I'd like you to get up slowly from the table because you might feel lightheaded. So take your time getting dressed. I'm going to go wash my hands and I will knock before re-entering, okay?
To aid in treatment and to help move things along, I'm going to give you some home care for you to do at home to help keep things going in the right direction. You're going to do 20 minutes a night of hot hydro, whether that be a hot shower or a bath, or a heating pad or water bottle, or even heating up a bag of rice in the microwave and using that as a magic bag type thing. You're going to do that for 20 minutes, and then you're going to do some active range of motion, so the motions that we did during assessment, so the flexion and extension and the rotation and then the lateral flexions. That will help maintain the range of motion. And also I'm going to get you to do a pec stretch after your shower or your heating pad. So what you're going to do is you're going to stand against the wall or in the doorway, and you're going to hold on, and you're just going to stretch so that you feel the stretch all in your pec muscles. Okay, and you're going to hold that for 30 seconds.
Okay.
Okay.
Okay, so I'm just going to give you some additional home care for postural education, just because you have the forward shoulders, and it will help lengthen your spine. So I want you to imagine that there's a string coming from the top of your head and that it's pulling your spine straight up. And I also want you to tuck in your chin slightly like this and roll your shoulders back And you should feel a slight stretch on the front of your chest due to the tight pec major muscles that we're going to work on in future treatments.